We are delighted once again. The NASMEC Secretariat is run by a team of people. I happen to be one of those supporting. This is Dr. Ladu, together with Dr. Richard. Like Ruth had said, we have been privileged to have a team from Bara help us coordinate today's session. It's a very wonderful learning opportunity for the entire health workers who are dealing with maternal and child health. We know COVID is the current thing, and that's in taking care of pregnant women who have COVID. So from the health workers that they need to get at least a session where we can learn one or two things. So we had wanted it to be a collaborative effort of the different facilities taking care of COVID-19 pregnant mothers. And like Ruth had highlighted, that we had invited a team from Entebbe Grade B, since in the Greater Kampala region, Entebbe Grade B is one of the main referral sites for pregnant women with COVID-19. Then also we wanted a regional team from Bara to also give at least their experience in the way they care about their pregnant patients, to have reached out to a few of our partners from the Royal College of Obstetrics and Gynecology, who were so willing within the short notice given to them to actually join in this session. So we will give them about 10 to 15 minutes at the very end after the presentations from Bara. They'll also give us the experience and one or two things, then we can have a few questions. So we'll beg that the presenters will keep time. I'm going to hand over the microphone to Dr. Ngonzi, who is our moderator of the day. He's going to introduce the commissioner, Dr. Mugahi Richard, who is going to give us a few remarks. He is quite a busy man, so join us shortly, give a few remarks, and then we'll be heading for another meeting. Then from there onwards, the session will be moderated by Dr. Ngonzi and the presenters and panelists from Bara, after which we shall have questions and answers, and then we should be able to conclude the sessions after the presentation from the ARACOG members. So I think I have tried as much as possible. I've got another guidance. You won't be able to join us, but Dr. Priscilla, I think Dr. Businje from Aogu is going to give a few remarks on his behalf. So I think let me hand over to Dr. Ngonzi, who should be able to take us through. Thank you.
Yes, thank you very much. Good afternoon, colleagues. We are delighted to see people from different parts of the world. People in Imbarara, in Kampala. I'm seeing members joining in from Kenya and other different places. This afternoon is a very special afternoon. My name is Joseph Ngonzi. I'm going to be the moderator for today. I'm an obstetrician, gynecologist, and I work at Imbarara University of Science and Technology. I have a team that has put forth today's presentation here. We are glad that we are able to be considered to host today's presentation about COVID-19 in pregnancy. So before we go further, we want to send appreciation to the Secretariat. Thank you for coordinating all these very important things. We shared a brief program where we are supposed to have a few, to have some opening remarks from Dr. Mugahi Richard, who is the Assistant Commissioner, Reproductive and Infant Health, Minister of Health, Uganda. But like we've been guided, we'll have Dr. Priscilla being able to speak. Dr. Priscilla is the president of the Association of Obstetricians and Gynecologists of Uganda. And today is a great relevant platform for her to be able to share a few remarks about this very important topic in COVID-19 management. Here, as Dr. Priscilla comes on board, in the room, we have the presenters. I have Dr. Onesmus, Byamukama, I have Dr. Levanti Waijuka, who is an obstetrician gynecologist. We have Dr. Ahabwe Onesmus, Dr. Kato Kalyebala, who is also a colleague in the Department of OB/GYN. We also have Dr. Kiwanuka, who is the incoming head of department soon in the Department of Anesthesia and Critical Care. Stella, Dr. Stella Choyagala, who heads our neonatal unit, is also one of the presenters, and she's online. Without further ado, it's exactly 2. Let me take the opportunity to invite Dr. Priscilla to speak a few words, and then we set the ball rolling. You're welcome, Dr. Priscilla.
Good afternoon, ladies and gentlemen. I have been hijacked at a short notice, so it's really, I'm very, very grateful to the organizers and the different universities and our colleagues from different societies and associations that are joining us in this webinar. I think this is timely, and COVID-19 in pregnancy has come in the right time where we cannot shy away anymore. And the nation, we are the backbone of the nation. Once we care for mothers and children, then the nation will have life. So we want also to thank the National Safe-motherhood group that has coordinated a number of webinars. And I'm sure the Assistant Commissioner to just ask me to step in his shoes, which are big shoes that I cannot handle. But I think he has the confidence that in the obstetricians of Uganda and beyond, we have the capacity to be able to guide the nation. This morning, we were validating a number of protocols, and there's been a lot of things happening. So this webinar has come in the right time, where we can guide the nation in the management of mothers and children with COVID. So I want to wish you wonderful deliberation. And Minister of Health, I'm sure, is very excited about this. And the Association of Uganda, all the obstetricians, we are really, really looking forward to this fruitful discussion. So I wish you a very nice afternoon and wonderful deliberations. Thank you. Over to you, moderator.
Yes, thank you, Dr. Priscilla.
Dr. Ngonzi.
Hello.
Yes, Dr. Ngonzi.
Yes.
I have just been guided that we have the commissioner online, and if we can grant him a few minutes, he could also add on the welcoming remarks from Dr. Priscilla, if that's okay with you, Dr. Ngonzi.
Yeah, that's perfectly fine. Dr. Priscilla.
Thank you so much, Dr. Ngonzi, and all our participants. My name is Dr. Richard Mugahi. I work with the Ministry of Health, and I'm extremely excited to be with you this afternoon as we share our experiences on management of COVID-19 in pregnancy. I want to specifically thank Mbarara University of Science and Technology under your stewardship for giving the leadership to host this webinar and moderate it. We are extremely proud of you. I want to also appreciate the partnership between the AOGO, and the president has ably mentioned that we can only win as a team and also lose as a team. But I'm extremely excited on behalf of the Ministry of Health, despite these tough times of COVID, that we are able to come together, share learning experiences for the benefit of our mothers and the newborn. I think a lot of activities are going on, and the time for this very webinar is also limited. I want to say that we have total support of the Ministry of Health. We look forward for any other future meetings and webinars, especially these critical challenging areas as more knowledge gets evolved. We all know that there are so many gray areas under COVID management, but coming together and sharing the experiences and the new information is very critical. Once again, I want to thank you and welcome you to this important and wish you very good deliberation. Thank you so much, Chair. Over to you, Dr. Ngonzi.
Thank you, Dr. Mugahi, for those welcome remarks. And thank you for being our advocate in those high offices. We are delighted to have people like you. So we are going to start off straight away on this important topic of COVID-19 in pregnancy. The outline is briefly as follows. We will have a case scenario presentation and pathogenesis of COVID-19 in pregnancy by Dr. Onesmus Byamukama. And then thereafter, we'll go into management of COVID-19 in pregnancy, then labor and delivery care of these mothers, postnatal care and neonatal care, anesthesia options. And then we'll hear from our colleagues who have joined in from the Royal College of Obstetricians and Gynecologists as they share the international experience. So let me invite Dr. Byamukama Onesmus to take us through the first part of the presentation, which is case scenario and pathogenesis of pregnancy. But on those slides, we shared with you a few pictures of what is happening in this site of ours here where we are managing mothers. The first part is, part of the team getting ready to deliver a mother by cesarean section who had COVID-19. The other one, we have team members after an infection prevention training. And then we see other members of the team by the newly constructed COVID treatment unit. So we want to welcome you all. Dr. Byamukama, please take the center stage and you set us off with the first presentation.
Yes, good afternoon, everyone. I'm Dr. Byamukama Onesmus, and I'm a resident in third year. This was to just highlight us on the cases that we have had we've had about 20 cases at Mbar Regional Referral Hospital of pregnant women. And of these cases, we admitted 8 of them. If you can just see the red colors, those are the critical cases that we've managed. And a number of these patients actually had comorbidities. We had a number of them with preeclampsia. We had 2 of them with diabetes. And I should say we've been able to save 1 patient out of the 8. And 7 of them have died. 2 have died on arrival though. And if you can look at the side of the baby, we've been able to save 3 babies out of these 8 critical cases. The rest of the cases, we've had about 7 cases of severe disease. We've had cases of moderate disease, and we have a number of cases that are on home-based care that are mild disease. I wanted to share with you a case, which is a 33-year-old female. She came in to us as a gravida 8 per 5+2, and she was at 33 weeks of gestation. She was admitted with a 1-week history of cough, fever, and vomiting for 2 weeks. But then 1 week prior, she had developed headache and epigastric pain. And she reported 3 days history of loss of fetal movements, but no difficulties in breathing. And all her prior deliveries were vaginal. She reported no history of chronic illnesses. When we examined her, her blood pressure was 220/127, and she was tachycardic and saturating at 96% on room air. But she was tachypneic and was a bit confused. We didn't appreciate the fetal heart sound. So she was admitted as a case of severe preeclampsia, but because of the history of cough and fever, the team suspected COVID as well, and as well as the IUFD. So the BPs were controlled with antihypertensives. We gave her magnesium sulfate, and induction of labor was started. But as she progressed in labor with a cervical dilatation of 7 centimeters, she desaturated and had reduced level of consciousness, and her saturations were 46%. At that moment, a COVID RDT was done, and it was positive. RBS was done, and it was RDT was negative. Her random blood sugar was undetectably high, and we later got her HbA1c, which was 14.1%. Nevertheless, with a negative RDT, we managed her as a case of COVID, put her on oxygen therapy, we ruptured membranes and augmented labor, and she delivered a 2.1 kg macerated stillbirth. She was started on insulin, antibiotics, and antihypertensive drugs, and continued with the rest of the COVID supportive treatment. Later on, her PCR came back and it was positive, and she improved on management after delivery, and we discharged her after 1 week, and she was stable. We reviewed her later after 2 weeks, and she's okay. Her blood sugars are controlled, and her blood pressures are controlled. That's one of the interesting cases that we thought we could share with you. Pregnancy per se causes immunological and physiological changes, like we know, and that puts women at risk of viral infections, and these viral infections include COVID-19 as well. And pregnant women rapidly deteriorate clinically, and this mainly occurs in the symptomatic pregnant women, and these are increased risk of severe disease and death. And some of the risk factors for severe disease and death include if someone is above or is 35 and above, if they are obese, and if they have some pre-existing medical comorbidities. So we know that severe acute respiratory syndrome coronavirus 2, which you can abbreviate as SARS-CoV-2, is a virus that causes the COVID-19 disease. And those are some of the variants that we have had. And I think right now we are facing a wave of the Delta variant, which was first detected in India. But then we've had other variants like the beta, the gamma, and some variants that were detected in South California. But we can see that the beta variant was actually detected in Africa, in South Africa. The transmission, we know that mainly through the aerosols, but other forms of transmission, the fomites, and then other portals of entry like the eyes, the nose, and the mouth. So it's very important that we know about this as we talk about IPC. Those will come out. So how does the disease come about? So in pregnancy, we know that you have an altered immune status, and this is basically to allow the growth of the semi-allogeneic fetus. The virus enters the body via the nasal passage and infects the pulmonary cells via the SARS-CoV-2 angiotensin converting enzyme 2 receptors. And they use the transmembrane serine protease 2 for protein priming. So the infection then is followed by viral replication and release of the virus, and that causes inflammation and later you have programmed cell death. So this inflammation causes the release of what we call the damage-associated molecular patterns, which include the ATP and the nucleic acid. And these trigger an excessive inflammatory response. And you have some of the pro-inflammatory chemoattractants like the interleukins, the chemokines, the interferons, which attracts monocytes and the macrophages to the infection site. So then you have a positive feedback loop, which leads to excessive inflammation and the damage to the integrity of the lung. And that results into the infection with other microbes like bacteria. And sometimes if the inflammation is excess, it can actually result into a cytokine storm that can later lead to a multisystemic organ failure. And during pregnancy, we know that there are some physiological and anatomical changes in the respiratory system, and these changes have an impact on the lung function. So the alteration in the chest shape and the elevation of the diaphragm by the gravid uterus, they actually reduce the total lung capacity and make a woman unable to clear secretion. And this makes these pregnant women more susceptible to severe infections. And we know that in normal pregnancy, there is an increase in the AC2 receptors and other components of the RAS. And sometimes you have physiological symptoms of pregnancy like dyspnea that can be confused with the symptoms of COVID. And that causes a delay in the diagnosis because initially patients will think probably it's because of pregnancy, but as well as clinicians might confuse some of these symptoms. So the alteration in immune status maintains an adequate response to these pathogens. But in the first and the third trimester, that's when you're likely to have more complications. And it's because of the alterations in the immune system. In the first trimester, the immune system alters allow or promote the implantation. But in the third trimester, it is to allow the delivery to occur. And that may evoke a higher risk of the cytokine storm. That's why you're able to see critical cases coming in third trimester and then first trimester. And we know that pregnant women are also at risk of other complications like DVT, stroke, and pulmonary embolism, and that even increases their risk to some of these complications the more. And you also have increased levels of stress during delivery and the physiological changes that occur postpartum that can actually contribute to the poorer outcomes that we see. A number of these cases come with preeclampsia, like you see, like you saw in my first table. We had 3 cases of preeclampsia. And we know that the normal blood pressure in pregnancy is maintained by the balance between the angiotensin 1 and angiotensin 2. But this balance is lost in pregnancy, and the blood pressures respond to the angiotensin 2 in an exaggerated way. And you also have the RAS abnormalities that are seen in preeclampsia, which may be potentiated in a patient with COVID-19. So the mechanisms for COVID-19 and preeclampsia are similar. Both of them do cause coagulation abnormalities, but as well as endothelial cell dysfunction. So these SCE2 receptors actually have endothelial cells, and these can as well be infected with the virus. So once there is an infection with the virus, you will still have the endothelitis, and we know endothelitis is a hallmark in someone developing preeclampsia. So you have endothelitis, which is caused by the SARS-CoV-2 infection, and that initiates a microvascular dysfunction. And we know that both preeclampsia and COVID-19, they both activate the complement system. So if you have a patient that has preeclampsia and COVID-19, you're actually likely to have severe forms of thrombotic vascular injury, and therefore you're likely to have severe forms of both diseases. So most of our patients in the first week, probably they will be confusing the symptoms with the symptoms of pregnancy, but you will most likely review these patients in the second week. And between day 8 and day 10, that's when they are likely to rapidly deteriorate. That's when you're likely to progress from moderate or even severe disease to critical disease. And that shows the severity spectrum. You have some of the mild diseases that can come with fever, cough, some of the symptoms, but no shortness of breath. You have moderate disease, the SpO2 is normal, but they have an evidence of a lower respiratory tract disease. And then you have severe disease, where you have the saturations dropping at less than 94%. And you have critical disease, where you have end organ damage, you have respiratory failure, septic shock, and other marked organ dysfunctions. So patients come present to us with symptoms that might include cough, a headache, muscle pains, fever, sore throat, shortness of breath, new loss of taste or smell. But then other patients might come to you with nausea, vomiting, fatigue, diarrhea. And I think in this current wave, we've seen many patients coming in with vomiting and diarrhea and headache than the usual cough and flu that people were using to suspect these cases. Yeah, thank you so much for listening to me.
Yeah, thank you, Dr. Onesmus. Yeah. So let's invite Dr. Ahabwe to take us through the second phase of the presentation.
Okay. Thank you very much, Dr. Byamukama, for the first part of the presentation. I'm going to quickly take us through the management of these patients in pregnancy. To begin with, these patients are battling an infectious disease. And yes, they have the disease, but as we take care of the patients, we do not need to get infected. Otherwise, we'll also be patients, and then we will not have people treat the next patients. So we shall begin with the infection prevention. And generally, we follow the general guiding principles for infection prevention and control. And infection control has different parts. We do infection control prevention measures in hospital settings, but also we need personal preventive measures as health workers and also for our patients. And the personal preventive measures include the hand hygiene or hand washing, social distancing, cough hygiene, and then the need to disinfect surfaces that are frequently touched. In other measures, we need to keep wearing our masks, especially as we go out to the communities to interact with other people or even interact with our patients. Then there's observation of the social or physical distancing and screening in high-risk settings. And I believe we are all in high-risk settings because we have lots of community transmission. This table elaborates the different levels of personal protection, and that it has level 1, level 2, level 3, and level 4. So with level 1, is where we have no interaction with the patient, but we do not know who the next potential patient is. So we do not necessarily need to put on very strong PPEs, but as a general measure, we need to ensure that we have clothes, masks, and closed shoes. Then levels, as the levels go down, we realize you need more and more protection as we go to managing these patients. In terms of investigations, we have diagnostic tests, general laboratory supportive tests, and even the imaging. So with regard to the diagnosis, the tests we do include reverse transcriptase PCR, which I think most of us are used to. The test is highly sensitive and specific and depends on the type and quality of the specimen, but the duration of the illness at the time we are testing. So there are fewer false
development. You can write my name there.
Okay.
of less than 5%, but like we have said, depending on the duration and quality of the specimen, the false negatives could go as high as even 40. Then we have a rapid diagnostic antigen test, which is very sensitive, and it's most sensitive 5 to 7 days after the onset of symptoms. The other tests that we do include the antibody tests, but they have variable sensitivity and specificity. So this table displays to us the different samples that we take, the rates of false positives and negatives, and the turnaround times for the different tests that we have to make the diagnosis. Then in other laboratory tests, like we have already highlighted, the disease is multi-system and will affect the different organs differently. And generally, the disease is marked by inflammation. So the markers that will highlight inflammation include the C-reactive protein, the ferritin levels, the electrolyte sedimentation rate, procalcitonin, interleukin-6, and tumor necrosis factor alpha, not forgetting the D-dimer levels. Then in blood, we have leukocytosis, but a lymphopenia, and then usually these patients have thrombocytopenia. With regard to the damage to the liver, the disease causes alteration in liver chemistries manifested by elevations in the aminotransferase and the elevations also in the lactate dehydrogenase. The effects on the heart manifest with elevation in levels of troponin and creatinine phosphokinase. We also have elevated prothrombin time, and like we may have read, there's alteration in the metabolism manifested with changes in the blood sugars. And so usually we have patients with raised random blood sugars or even fasting blood sugar, like in the case scenario we have. And this table displays the different levels of the tests that we've been looking at, and you look through it as you get the slides and try to also internalize it. With regard to imaging, we can do a chest radiograph or a CT scan, and the features on the chest radiograph can be normal initially in the early stages of mild disease, but the typical features will be ground glass opacities that are usually in the posterior and peripheral lung zones, and usually these opacities are bilateral. You can also have consolidations, and important to note is that these features are more pronounced 10 to 12 days after the onset of symptoms. Then the CT scan findings, which can be typical of the disease, but can also be atypical and indeterminate. So this table displays to us the typical findings of the CT scan, and these are usually in the peripheries, bilateral ground glass opacities, with or without consolidations. The ground glass opacities are usually multifocal, and you usually see a reverse house sign or other features of organizing pneumonia. So what is the care to these mothers? The care to these pregnant mothers with COVID is usually based on disease severity. And we can have patients with COVID but asymptomatic, or those
with symptoms. So the asymptomatic mothers, we need to assess their risk of developing severe disease, and we do cross monitoring for respiratory decompensation. So initially they will have no symptoms, but they have a COVID test positive, and over time they can decompensate and develop symptomatic or even severe critical disease. And then the other thing we need to look at is the infection control and self-isolation to ensure that they do not transmit the disease to other health mothers or members of the family. So for the symptomatic mothers, the care depends on the disease severity, the underlying medical conditions that may have or coexistent pregnancy complications, or their social situations. There may be mothers who are pregnant, they have the COVID-19, and they can't afford even the self-care, or their follow-up in the communities are really difficult. So we realize that as we care for such mothers, these are mothers who will have, yes, mild symptoms, but need to be cared for in the hospital for the social disadvantage that they have, and we may not easily get to them in case they decompensate. So for the home care, it involves the patients with no shortness of breath, and we need to follow up closely for progression to severe, moderate, severe, or critical disease. So we need to give this mother instructions on infection control, symptom management, and warning symptoms that may indicate that the disease is getting actually severe. Then we need to follow them at least once after the diagnosis of COVID has been made. And for the homeless, like I had said, we need to accommodate them and monitor them in our health facilities. So what is involved in the home care? This is basically supportive care, and it involves 14 days of self-quarantine, and we advise mothers on adequate hydration, adequate rest, and frequent ambulation to as much as they can tolerate. The supportive treatment to these mothers involves use of zinc sulfate, vitamin D, and previously we used to use vitamin C. That's now being discouraged for fear of the observation that there are people that have developed renal stones from vitamin C. And we realize that these are supportive treatments that modulate the immune system, try to counter the inflammation and help this pregnant mother or even another person with COVID to fight the virus. There are also monoclonal antibodies that are undergoing trial for use in supportive care for these patients. Also, we need to ask these patients to call back in case they have worsening dyspnea, they have unremitting fevers of greater than 39 despite use of the antipyretics, patients who are unable to tolerate oral medication, mothers that develop pruritic chest pain, those that get confused, or any of the mothers that gets obstetric complications. They may have rupture of membranes or vaginal bleeding in pregnancy, and these mothers would need to come back. The other features to look for are respiratory rate of greater than 24 and pulse rate of greater than 100, which are indicators that this disease is actually progressing to the worst stage. We realize in our setting that these are clinical measurements or observations, and patients may not be able to quantify, but at least the members of the family or even the patient themselves, they realize that I think my breathing is getting worse. I need to get to the hospital. That pictorial is about the vitamin C, and it shows us that it is an immune modulator. It has an indirect antiviral effect, anti-inflammatory effect, and antioxidant effect, the same as vitamin D and also zinc. But like I said, we're tending to use more vitamin D and phasing out vitamin C. So this patient who has been undergoing home care, if the disease worsens and needs a hospital or inpatient care, the features will be oxygen saturation less than 95. We do recognize and appreciate that we need saturations of 95% and above to be able to deliver adequate oxygen to the mother and the fetus in utero. Mothers who will have exertional oxygen saturation demands of less than 95% in room air, we need to consider inpatient care. Then there are mothers with comorbid conditions. If they have hypertension, they have gestational or pre-gestational diabetes that is not adequately controlled, even with a moderate disease, they need to be admitted for these reasons. You have mothers also with chronic diseases like renal and cardiopulmonary disease or immunosuppressed patients. And also patients who, after 37 weeks of gestation, we need to be admitted and plan their delivery for the disease course cannot be predicted, and yet they're already at term. So you need to admit them and plan their delivery before they decompensate. So in the hospital, the care involves maternal respiratory support, venous thromboembolism prophylaxis, dexamethasone for the disease itself, but also fetal lung maturity for mothers that will be preterm, paracetamol, antiviral drugs, and fetal monitoring, among other things, but also to monitor for preterm labor. So about dexamethasone, it has been shown to decrease mortality in patients that do require oxygen therapy, especially those that will be on mechanical ventilation. So when glucocorticoids are required for fetal lung maturity, the dose is 6 milligrams of dexamethasone given twice a day for 48 hours, and those are 4 doses. And then we follow this with 6 milligrams per day for at least 10 days. When you have a patient with severe or critical disease, but does not require glucocorticoid for fetal lung maturity, now the dose goes to 6 milligrams per day for 10 days, and that is as in the non-pregnant patients. We do appreciate that occasionally you may not have dexamethasone, but hydrocortisone, methylprednisolone, and prednisolone have been shown also to offer benefit to these patients. The antiviral drugs, remdesivir is one of the drugs that have demonstrated decreased duration of the disease among patients with COVID-19 that do require oxygen therapy. And it has been studied, and there's no known fetal toxicity with the drug, and so may be one of the antiviral drugs offered to these pregnant patients with COVID-19. As regards antibiotics, if bacterial infection is suspected, we treat with appropriate antibiotics. If, for example, the infection is a community-acquired pneumonia, ceftriaxone with azithromycin, or ceftriaxone alone, or with coamoxiclav can be an option. Then where patients have hospital-acquired pneumonia with severe disease and mechanical ventilation, drugs like meropenem become options that are feasible and safe in pregnancy. Regarding anticoagulation, these pregnant mothers are already at risk of venous thromboembolic events, and they need prophylaxis against thrombosis. So for patients who are critically ill, unless therapeutic dosing. Now for patients who are having severe or critical disease, they need prophylaxis. And the options include low molecular weight heparin that may be preferred due to its once daily dosing and limits the exposure of the patient, of the health worker to the patient, thus reducing the risk of transmission of COVID from the patient to the health worker. But we consider unfractionated heparin because it has a shorter half-life and reversibility with proptamine sulfate is faster, especially when we are planning an imminent delivery, bearing in mind that this mother is likely to bleed at delivery. Magnesium sulfate is an important drug with regard to neonatal neuroprotection, but we need to be careful as these mothers already will have respiratory compromise, and so we need to monitor magnesium levels, the respiratory rates, and pulse oximetry, so that we detect the signs of toxicity at the earliest time they appear. And we do appreciate that there are also patients who may have had acute renal injury due to the disease, and these mothers will require dose adjustment for magnesium sulfate, but not withholding it for the benefit to the baby. It's more difficult for intubated patients, as monitoring this respiratory rate is harder because they're usually even sedated with intubation, and the only sign may be cardiac arrhythmias or arrest as the first clinical feature of magnesium toxicity. Consideration for intensive care unit care, we need to abstain ICU consult in situations where the saturation does not stay above 95 with supplemental oxygen, or oxygen requirements are increasing rapidly and may not be achievable on the ward. Mothers that get hypotensive with a mean arterial pressure of less than 65 millimeters of mercury, despite the attempts at resuscitation. And then if we have new end organ insufficiency that involves renal, liver, and cardiac or neurologic effects, these mothers need to best be cared for in ICU. There has been literature with regard to prone positioning in pregnancy and its effect on improving oxygen delivery. So it can be done in pregnancy and in postpartum period, but we require padding of pillows so that you protect the uterus against the weight of the mother. So for intubated patients, we need to be careful that the tube remains in place.
They are not doing.
And that picture demonstrates the effect of putting the patient in prone position. And we realize that there's more expansion of the alveoli, and thus more oxygen delivery with prone position. The disease is not without complications in the mothers and also in the fetus. And the complications, we've tried to list them with regard to the systems that are most affected. So in the respiratory system, we will have COVID pneumonia. You can have acute respiratory distress syndrome, or even progressing to respiratory failure that usually ends up in death. In the cardiac, we have arrhythmias, acute cardiac injury, myocardial infarction, among others. Then you do have thromboembolic disorders due to the hypercoagulability state in pregnancy, but also as induced by the disease. Secondary infections are also common, and neurological disorders, including psychiatric patients. And gastrointestinal tract or liver disorders are also common. We also have noted that there is increased chance which doesn't go without complications. As far as the fetus is concerned, there is risk of miscarriage, iatrogenic preterm delivery with associated complications, increased rates of stillbirth, and rarely maternal to child transmission of COVID-19 disease. If we do manage to take care of this pregnant mother and she recovers, how do we follow her up? Telehealth is one of the modalities for follow-up to ensure maternal well-being. So we need to keep in contact with the mother on phone or any other means than the physical meeting of the patient as an option to follow them up. We need to have appointments that are scheduled after the end of the infective period, and usually about 4 weeks after the onset of symptoms or after a negative test. Routine antenatal care assessment of pregnancy risk, fetal growth, and well-being need to be continued, but we need to ensure that the mother is after a period of 2 weeks, those can be combined and done at the same time to reduce the risk of disease transmission from some of the patients or even the healthcare workers. We need to do serial ultrasound scans in the third trimester at 28, 32, and 37 weeks for fetal growth monitoring. And if follow-up assessment is required within the contagiousness period, we ensure that the protection measures are observed. As far as vaccination and pregnancy, we know vaccination has been studied and shown to prevent severe and critical disease. And we have literature that shows that these vaccines currently available are safe in pregnancy and also in the lactation period. And these mothers should be offered vaccines like any other person. And the best vaccine to give to the mother is the one that you have. And like we've already said, the vaccines we have are all safe and effective and reduce the severity of the illness and death. And CDC, or Centers for Disease Control, does not report preference for one vaccine over the other. But it's advisable that we have a minimum interval of 14 days between routinely administered vaccines and the COVID vaccine series. However, in situations where a vaccine is urgently required, and I think a cited example is the tetanus vaccine in a mother who has had an injury and is at risk of getting tetanus, then you do not have to wait for all the 14 days. So you offer the vaccine to the mother. I now hand over to the next presenter to take us through labor and delivery.
Yeah, thank you, Dr. Ahabwe. Let's have Dr. Kato take us through the next phase of the presentation.
Good afternoon. I'm Dr. Kato Kalewara, as introduced. I'm an obstetrician gynecologist at Imbara Regional Referral Hospital and a lecturer at MAST. Now, COVID-19 is a relatively new disease, and there is no consensus about some of the interventions that are done during labor and delivery. But these are some of the areas that you should consider. Now, some of the mothers that will come for delivery will have been isolated at home for some time. It is important to note that there is increased anxiety and depression among these mothers. Therefore, we should have in place tools and protocols for assessing for anxiety and depression. And also, we should allow the mother the opportunity to have a caregiver or a birth partner of her choice. And we should provide this birth partner with appropriate PPE that is available to us. We know that we not interface with infectious diseases in obstetrics and gynecology very frequently. It is recommended that we have periodic training and drills for maternity staff in the use of PPEs, donning and doffing PPE. We should have protocols within our maternity units for task-specific or task-appropriate PPE. In Imbara, we are using level 3 PPE during labor and delivery. It is of importance to note that some of the mothers will require an emergency intervention. PPEs might be perceived as though they cause a delay, but it's important that we adhere to the use of PPEs even when we are performing an emergency cesarean section. We should know that general anesthesia, the intubation process, is an aerosol generating procedure, and this will require us to use level 3 or level 4 PPE. The next consideration is teamwork. The next consideration during labor and delivery is teamwork. We should ensure that we have limited staff in the labor suit, but at the same time, we should have a team that includes a midwife, an obstetrician gynecologist, and a physiologist and a pediatrician to address the different issues that arise during labor and delivery. We should be able to manage the delivery suit, and it is recommended that we have a separate delivery suit for mothers with COVID-19 where possible, and that we should adhere to the protocols of decontamination, IPCUs, and engineering controls. We should also be able to manage the operating room. If possible, or where possible, we should use a separate we should be able to manage the operating room. We should have a separate delivery room for mothers with COVID-19 where possible. Where not possible, we can use the same delivery room, but we should adhere to decontamination protocols. There are challenging cases of mothers with COVID-19 that we should be aware about. And the approach recommended to addressing or managing mothers that are challenging is to have consultation with colleagues that have specialized in the particular fields where the mother has a complication. We should involve the mothers and their families in decision-making to have shared decision-making. So one of those scenarios that may be challenging is where we have a probable case of COVID-19, but we do not have a testing facility that is available at that time. Then these mothers should be treated as confirmed with COVID-19, even though they don't have a laboratory confirmation. The obstetric complications that mimic severe or critical COVID-19 disease, such as preeclampsia, HELLP syndrome. And so we should be able to notice that some of the presentation may be confusing because of complications that present the same way. Mothers that have thrombocytopenia as a result of COVID-19 may be challenging to deliver, and we should have consultation with physicians, with hematologists. The same with mothers that get multiple organ injury or acute organ injury. Mothers that have severe or critical COVID-19 are challenging. Mothers with refractory hypoxemia, and there are reports that some forms of coronavirus infection are associated with intrauterine growth restriction. So we should anticipate that some of the babies, some of the fetuses will have IUGR. We should also know that in some instances, we are required to have a preterm delivery, and therefore we need to prepare adequately for that. There is room for obstetric analgesia during labor and delivery, and as we shall listen later on, epidurals are acceptable, Etonox is acceptable. However, each patient should have a separate microbiological filter. Now, concerning the level of health facility where the mothers with COVID-19 can deliver, For critical disease and severe disease, it seems to be clear that these mothers should deliver within a tertiary or referral health facility, including the mothers who have recently recovered from severe or critical COVID-19. However, for mothers that have moderate disease and those that are asymptomatic, there is no SOP, there is no standard operating procedure that defines whether at what level of health facility they can deliver, whether at health center 4, at district hospital, there is no clear guidance. For preterm delivery because of COVID-19, COVID-19 infection in itself is not an indication for preterm delivery. However, with team consultation and shared decision-making, when we think that preterm delivery is going to facilitate a resuscitation of the mother, then preterm delivery may be warranted. And also in situations where there is worsening acute organ function, where there is refractory hypoxemia, where there is fetal distress. We have already heard that antenatal steroids such as dexamethasone are acceptable. Magnesium sulfate for fetal neuroprotection is acceptable. And where the mothers, especially those with severe and critical disease, require anticoagulation, then unfractionated heparin is preferable to low molecular weight heparin. And this is because unfractionated heparin has a shorter half-life and can also be easily reversible using protamine sulfate. Now, about mode of delivery, this is an interesting area, but it is still gray. There is no particular mode of delivery that is favored over the other. However, cesarean section is recommended when there is fetal or maternal compromise, yet vaginal delivery is not imminent. For vaginal delivery, induction of labor is acceptable. However, the mothers must be carefully selected. We should be aware that there are several reports about deterioration of mothers with COVID-19 during the second stage of labor, particularly mothers who are 35 years and older, those that are immunocompromised, those that are obese, those that have gestational diabetes or pre-existing diabetes, and those that have asthma. So there should be individualized decisions about shortening the second stage of labor by instrumental delivery. Oxygen during second stage of labor should be, oxygen saturation should be maintained at more than 94%. So, the assessment of women during labor and delivery. So mothers during labor and delivery should be assessed for severity of the COVID-19 because the severity of disease can vary from time to time. We should do standard obstetric assessments as well to confirm labor. And also we should monitor the mother using standard protocols and standard tools such as the pathograph or the WHO labor care guide. In addition to the usual parameters that we monitor on the pathograph, we should do hourly oxygen saturation, respiratory rate, and temperature. For fetal well-being, what is recommended is continuous electronic fetal monitoring using a CTG, but we well know that CTG is not available in many facilities. At Imbara Regional Referral Hospital, we have been doing intermittent fetal heart measurement using a handheld Doppler. However, there is no standard protocol at the moment. There is no consensus as to whether intermittent fetal heart rate measurement using Doppler is a standard of care. The standard of care for now is CTG. Concerning the timing of delivery. Now for asymptomatic mothers, those that have a planned mode of delivery, for example, a planned elective induction or cesarean section. These mothers, the delivery should be delayed for 7 days from the onset of symptoms and 3 days after resolution of symptoms, all for 14 days after a positive test of COVID-19. For mothers that are early term, asymptomatic early term meaning that they are at a gestational age of 37 weeks, 0 days, up to 38 weeks, 6 days. Expectant management can be done for these women until 14 days after a positive test, all 7 days from the onset of signs and symptoms, and 3 days after resolution of signs and symptoms. For mothers that are asymptomatic and at full term, that is 39 weeks and above, these mothers should be delivered. The mode of delivery still depends on the considerations that we have seen before. For mothers that have severe COVID or critical COVID. Now, these mothers' mechanical ventilation in itself is not an indication for delivery. However, delivery is recommended if the mother's condition is worsened, particularly if the mother gets refractory hypoxemia. So it is said the mother has refractory hypoxemia if the partial pressure of oxygen is less than 60 millimeters of mercury, or if the ratio of the partial pressure to the fraction of inspired oxygen is less than 100. And or if the oxygenation index is less than 40, then the mother has refractory hypoxemia. And if the gestational age is less than 32, it is important that we first explore with an anesthesia team and critical care teams, advanced ventilator options that might help improve the oxygen saturation in this mother before we decide delivery. However, if there is no improvement in the oxygenation, then delivery is required. If the mother has hypoxemia, a refractory hypoxemia, and the gestation age is more than 32, then delivery is recommended, as this may optimize her care, this may minimize the work of respiration and other physiological demands. And also it will avoid the need for a peri-mortem delivery, as the mortality rate is high for mothers that have refractory hypoxemia. So with this is the conclusion of the considerations that that we have during labor and delivery. It takes us to the enforcement of care for COVID-19 mothers.
Yes. Yeah, thank you very much, Dr. Ngonzi. Thank you. You're welcome, the entire team attending the webinar. I am Dr. Levan Tiwaijuka, an obstetrician gynecologist at Mbara Regional Referral Hospital. So the consideration about postpartum care, really, we have to think about the basics, which range from taking the routine precautions while taking care of these mothers. There is need for observing the standard, the infection prevention protocols, isolating these mothers during the care, but specifically in relation to the postpartum monitoring of these mothers for asymptomatic or mild illnesses. It's important to check the vital signs of these patients every 4 hours, especially for the first 24 hours, especially for these patients who have had vaginal deliveries, and of course 48 hours for the women who have had cesarean section. For moderate cases, it's always important to do continuous pulse oximetry and monitoring for the first 24 hours until clinical improvement of the women. In severe or critical illness, usually needs more closer monitoring. And of course, this is an indication for ICU care for these women. The analgesia postpartum really is mostly the routine with acetaminophen or this may be necessary for management of the pain of these women. it is very important to consider venous thromboembolism prophylaxis, especially that these women are at great risk of deep venous thrombosis and pulmonary emboli. And of course, it's good to give the prophylactic anticoagulants, preferably heparin. If they can, you may give enoxaparin about 40 milligrams once a day, and or deltaparin. If the weight of the patient is more than 80, you may give up to 60 milligrams once a day. And usually this can go between 10 to 14 days, unless contraindicated for some of these patients. Consideration has to be put into plan, especially before delivery, where you might have to stop for up to 24 hours on this heparin. And restarting of the heparin may occur for vaginal delivery between 4 to 6 hours, while for the post-C-section, you may want to wait for 6 to 12 hours. We need to consider increasing the duration of the prophylaxis to up to 6 weeks, especially for these patients with additional risks of those have been on who require the anticoagulation a little longer. It is good to note that heparin is safe during breastfeeding, so there is no worry for you continuing with the thromboembolism, since it may not cross to the baby. The previous presentations have noted much of deterioration, but it seems to be a little higher in the postpartum period. And of course, several case series and some studies have reported improvement of some of these women. However, majority of them are reporting deterioration, especially in this early, in the postpartum periods. It's usually sudden, mostly within an hour, a few hours, or even 1 week of delivery of this patient. And some have even deteriorated after discharge and required readmission. Well, this has been evidenced by the worsening of the clinical features, the laboratory tests, and even the the CT scan findings. We think through what may be causing some of these deteriorations, and possibly this could be because of the natural course of the disease, that when the disease is very severe, when in mild cases, may actually be progressing to severe or critical. But typically in the postpartum period, we notice the worsening pulmonary edema, likely because of the synergistic effects of the natural postpartum period, the physiology, and of course the pro-inflammatory viral states being caused by the COVID-19. And it's also not good to think about the venous thromboembolism that is likely to happen, DVTs and the pulmonary embolism. And of course, these are all worsening around the third trimester, where physiologically the coagulation factors will rise. And this is coupled with the cytokine storm from the COVID-19 infection. We also need to think about the potential of the immune reconstitution syndrome happening in early postpartum following the largely immunosuppressed period of the pregnancy, and the body reacts by producing more inflammatory markers which may elicit the pathogens, in this case the COVID-19, and this may potentially worsen the clinical state of the patient. It's also good to think about the comorbidities, think about the cardiac diseases, diabetes, hypertension. All these could play a role in worsening this patient. Also, very important to think about the other complications in the postpartum movement, which may include the endometritis, the surgical site infection, and other sources of infection in this patient, which could possibly contribute to deterioration. Also, another question running through the mind is whether the delivery mode has impacted on the clinical deterioration. It is true that most deliveries in these circumstances have been by cesarean section, as evidenced by some studies in China, up to 89% being by cesarean section, the cesarean section rates. In USA, up to 38%. In the journal COVID-19 women in pregnancy. However, for critical illness, it has risen up to 94%. However, there is no adequate evidence that the route of delivery really adversely influences maternal prognosis. However, a study in Spain in 96 health centers noted that cesarean section was associated with 13.4 times the risk of deterioration of these mothers, and also worsening the associated with severe maternal outcomes compared to women who had no or mild symptoms who delivered vaginally. We definitely know that surgery and induced physiological stress may increase complications in postpartum women, but also it's worth to note that COVID-19 and cesarean section are just independent risk factors for venous thromboembolism, which is one of the serious complications that may be happening in these women. So it's good for us to actually take heed and be careful around as we take the decisions. It's important to individualize and have a multidisciplinary approach as we deal with these patients, and careful consideration of the expected risks and benefits of the expectant obstetric management versus the delivery. And now that we know the delivery itself, as much as we wish to deliver, maybe save the mother or save the baby, it may be the time we are sentencing them to the worst postpartum period. It's also very good to closely monitor women with COVID-19 in the postpartum period. Also, we may have to consider delaying discharge of these women, irrespective of whether they are mild or moderate or without symptoms, because they might likely come back with a severe or critical state. Discharge from the hospital really should be individualized based on the patient's clinical status prepartum. However, in asymptomatic or mild disease, especially those without comorbidities, we may discharge them and let them recover from home. We know there may not be a lot of space in our hospital settings. However, in severe or critical disease, it's important to continue inpatient observation and management. And also, however, routine postnatal review should be maintained at 6 weeks. Since this COVID-19 has been associated with exacerbation of depression and anxiety, it's very important that at 4 to 6 weeks after delivery, there may be consideration to do a screening for depression. Employing psychoeducation to help patients cope with this stress would be important, ensure adequate rest, healthy diet, and also regular exercise, among others. I thank you as we welcome Dr. Stella.
Yeah, Dr. Stella, you're online. We shall navigate through with you.
Thank you, Dr. Ngonzi.
Thank you.
And thank you, Dr. the previous presenters from the obstetric team. I'll be talking about neonatal assessment and care. I'm Dr. Stella Choyagala, a pediatrician in the newborn unit at Imbara Regional Referral. And I'm grateful for the pediatric invite in your presentation. I'll make this as simple as possible because, as you're aware, in most of the delivery places, be it in big centers, you will not have a pediatrician or neonatologist, but you'll be dealing with a neonate most of the time by yourself still. So the obstetric team has talked a lot, and I'll just reemphasize a few things concerning prenatal and antenatal consideration in COVID-19. One is that sexual and reproductive rights still remain respected even during COVID-19. There's no particular reason for you to tell a mother or a couple not to have children during the pandemic if they would wish so, and if they are fit to have a child at that point. So we should respect couples' rights to go ahead and still carry the pregnancy and have the children that they wish to. Now, a lot has been said about vaccinations and infections of COVID-19 in the first and second trimester. And we largely agree that vaccinations have been said to be safe at any point, either before conception or during pregnancy, whether it's in first or third trimester. Now, the few vaccines that had actually studies done on Moderna and Johnson & Johnson, and even then the studies were really on small numbers to show that they are safe in pregnancy and even just before pregnancy. The other vaccines are said to be safe, but a lot of studies are still lacking to actually back up that. So we still go with the recommendation, as said before, that whichever vaccines are available, as long as the parent has accepted to take the vaccine, or as long as the mother is a high-risk mother for severe COVID disease, you should advocate for them to be vaccinated. And the same thing goes for infections. A lot of mothers get concerned that they've just recovered from COVID and now they realize they are pregnant. I think we should allay their anxiety, because at the moment, we do not have clearly documented content abnormalities associated with COVID infections. So mothers shouldn't be really worried that probably they are going to have a child with particular abnormalities because of the COVID infection or because of the vaccine. There's no clear evidence yet that COVID-19 crosses the placenta. So mother-child transmission through the placenta or during the antenatal period is rare and is not yet clear. So largely the few studies which have been done actually show that there is no COVID-19 transmission during pregnancy directly from mother to the child as form of vertical transmission. So most of it actually after delivery from still respiratory aerosols. And COVID infections really does not, it has been said that it wouldn't really make the mother get more severe symptoms because of the pregnancy, especially in the first and the second trimester. However, in the third trimester, as we know, a lot of other comorbidities come in third trimester and a lot of compromise, as explained earlier on. So third trimester, COVID infections during the third trimester tend to increase the risk of complications, both to the mother and the fetus. And some of them which have been seen is preterm rupture of membranes, sorry for that, I was briefly muted, but I hope you can hear me now. Yeah, so fetal distress and then preterm deliveries, which sometimes are brought about because of medical recommendations and not necessarily because of COVID. So the recommendation largely is that if a mother is pregnant, they should try as much as possible to avoid exposing themselves to COVID. And if they are working in high-risk places like hospitals, they should be kept away from the high-risk places, like from working in COVID ICUs and all that, until they have finished delivery. Now, delivery considerations, these deliveries should be done in an isolation place away from the usual delivery places, as mentioned from the obstetric team, and the staff is encouraged to have full PPE protection. Reason being that, and from experience that we have seen, is that once the staff are not fully protected, they would want to rush through the process of delivery to give themselves little exposure. So if they are fully protected, they are willing to go through that delivery well and have the time to explain to the mother all the necessary things in terms of delivery and care for the newborn. So we should try and advocate for that as much as possible. And the delivery has exhaustively been discussed. I will not repeat that, but management of emergencies, both in the mother and the baby, should remain standard, including neonatal resuscitation. Now, delayed cord clamping and skin to skin are still safe even in COVID infections, and the benefits are the same in a mother with COVID-19 and their baby. So we encourage that we should continue practicing delayed cord clamping and encourage the mother to do skin to skin during delivery and even after delivery. And this is because COVID-19 transmission to newborns is entirely through respiratory droplets. And most of these are actually going to come either from the mother or other caretakers or the health workers. So that will not, our child is not really exposed to COVID from amniotic fluid or from the birth canal as such. Next. Now, evaluation of the newborn, assuming that, that the delivery was successful and the necessary resuscitation has been done. How do we evaluate a newborn maybe who has been delivered to a mother with COVID or who is coming in symptomatic? One thing we have to keep at the back of our minds is that neonatal COVID-19 is actually a bit rare. It is not common for newborns to get COVID-19, be it even when they are in the community. And then those who get the infection, majority of them are actually asymptomatic. A few of the newborns will present with symptoms of COVID-19. So, and those who are at risk of severe disease are mainly prematures or those who have already underlying comorbidities like congenital cardiac defects. So in case a baby got a severe birth asphyxia and now has COVID-19. And the presentation is not different from other children, except that the symptoms are similar to most of the other conditions that disturb newborns. And that is usually fever, lethargy, they may have rhinorrhea and sometimes congestion, nasal congestion. And then difficulty in breathing in terms of increase in respiratory rate, grunting, chesting, drawing, and then vomiting and diarrhea. These are not really common in newborns, vomiting and diarrhea, but when they also happen, we should consider the possibility of COVID-19, especially if the baby is exposed. And of course, poor breastfeeding. As you realize, these are the same things which happen in sepsis and asphyxia and respiratory problems in newborns without COVID. So really our suspicion should be high and should be based on the fact that you already have a previous exposure, either from the mother or from the attendant or from the health worker who has been looking after this newborn. Now, when a baby has been born to a mother with COVID-19, it is always a must, or it is always encouraged that we try and confirm and see if the baby got infected along the way or after delivery. And the tests are the same that we do in adults. The PCR, the swabbing is similar. We can do a nasopharyngeal swab or oropharyngeal swab. And then who to test in newborns? We only test newborns who are symptomatic with a prior history of exposure to COVID from either the attendants or from the family members or from the mother. And then for those who are not symptomatic, we only test those whose mothers are known or highly suspected to have COVID-19. So it's not that every newborn who walks in the hospital should have a COVID test. At least there must be a prior exposure, or the newborn should be at least symptomatic with a positive history of exposure. Reason being that if you test all symptomatic newborns, you're going to literally test all newborns who come in for admission because they will have all these symptoms that we have talked about. So without a known exposure, it is not recommended to test these newborns for COVID. When should the test be done? That is basically after 48 hours. A lot of recommendations keep saying you could test within the first 24 hours. And if it's negative, then do a repeat test after 48 hours. But in our setting where our resources are not adequate to really have all those tests done, we recommend that if the baby is asymptomatic, we wait until 48 hours to be tested, and then the baby can be discharged thereafter since they are symptomatic as they wait for the results. And then if the baby is symptomatic, definitely you test the moment they come in. So concerning routine care, we encourage the following as long as the baby and the mother are actually stable. The same routine care practices are still encouraged even in COVID-19. So we encourage rooming in. At least the mother, once the mother and the baby are fine, they should stay in the same room. In case the mother is not so comfortable having the baby probably on the same bed with her, the baby can be kept in a separate couch, but within the same room. And this is beneficial because we want the mother to continue bonding with the baby, to continue breastfeeding, and it also releases the anxiety of not knowing what is happening with the baby, okay? And then we only do temporary separation for medical reasons. That is if the mother is actually very sick and she needs intensive care treatment, or she needs a really close HDU management where the baby will not be given time, or in case the baby is the one who is very sick and also needs to be admitted. So that is the only time we would recommend separating the two so that they get attended to without interruptions. Other than that, if they are all well, exclusive breastfeeding should be done and should be started right after delivery. And then, as we said, skin to skin at delivery, and also continued for the small babies below 2.5 kilograms is okay. That is kangaroo care is fine. And then routine immunization should be encouraged. Once the baby is asymptomatic or they are negative for COVID, they should get their vaccines as per schedule at delivery and then continued as per schedule. However, if the baby is very sick, or in case the baby is symptomatic and unwell, we can wait, we can delay vaccination until the baby's condition is stable or until they are ready for discharge, and then we can do the immunization. And however, one thing we have to notice that infection prevention has to be paramount. The mother, as we shall see, how we should encourage the mothers to do infection prevention in the next slide. Next, please. So what we recommend in terms of infection prevention for the mother, caretakers, and the baby is that the mother should wash their hands frequently with soap and water for at least a minute as recommended. And if not, maybe they should use alcohol rub, and that should be all the time before they touch the baby, or after doing respiratory hygiene, or after coughing, sneezing, and cleaning their nostrils. And then we need to keep regularly cleaning the surfaces where they are with alcohol and with probably Dick at least as frequent as possible. And then for respiratory hygiene, this mother, as she stays with the baby in the room and or an attendant is taking care of this baby, we should encourage them to wear a medical mask. That is either N95 or a surgical mask. And then this mask should be replaced as soon as they become damp, especially for mothers who are having running nose and all that. And then dispose that mask immediately and not reuse it. So they should be provided with enough masks to keep changing. And then as they wear the masks, they should use the strings to untie and not keep touching the front of the mask with their hands. And then they should have tissue for blowing in their nostrils and disposal, for easy disposal. And then for feeding, we've said that breastfeeding has to be encouraged for all mothers. Now, in case a mother is unable to breastfeed, or in case the baby has been taken away for care from the mother, this mother should be taught how to express breast milk and send it to the neonatal unit for the baby to continue breast milk exclusively. And during the breastfeeding and the expression of breast milk, again, hygiene has to be maintained, especially hand washing. And then the baby and the mother, the distances between them is largely a discussion between the health worker and the mother. We encourage that the mother is free to stay with the child, because staying with a baby in the same room or in the same bed doesn't seem to actually increase the infection that much from mother to the baby. And initially, that is what it was recommended, that they should be separated, but following studies, it was shown that there's no increase in transmission of COVID, even if the baby stays in the same place with the mother. Next, please. So after, in case the baby is unwell, how do we care for them? And as we said, usually it's only symptomatic neonates to be admitted. Otherwise, the baby is encouraged to stay with their mother. And then admission is encouraged to be in also a neonatal isolation unit. However, if this is not available due to lack of space, they can be admitted in the same NICU with the other babies who are not having COVID, but it should be in a separate corner, at least 6 feet away from the rest of the babies. And then the staff and attendants have to practice good infection prevention, especially when dealing with this baby who is having COVID, but also to make sure that if they're in the same room with the other babies, they also do not increase the risk of transmission from that baby to the rest of the babies, okay? And since COVID symptoms are similar to other neonatal conditions, these babies should be evaluated and managed for these conditions in case they are suspected. That is, if in your assessment you see that the symptoms they are having are similar to sepsis despite having COVID, sepsis treatment should still be initiated, okay? And for the sick newborns, other than the COVID test, the additional lab evaluations are to look out for mainly the other infections, and also to see if they are having complications from the COVID infections. So things like a lab workup, especially, we can have a CBC done. You may find neutropenia in most newborns, but that also happens in neonatal infections. And then C-reactive protein or procalcitonin may be elevated in COVID, but they can also be elevated in neonatal sepsis. And then blood cultures to ensure that there are no superimposed infections, or it is not just sepsis happening in the presence of COVID. Chest X-ray for respiratory symptoms is not recommended for all babies unless they are having respiratory symptoms. Then CSF analysis is important. One, because it may be neonatal meningitis, but sometimes we've seen a few babies with COVID presenting actually with the viral meningitis. So I don't know if the headaches in adults are also a meningitis something, but in newborns and very young infants, we've seen that there is a related meningitis from COVID. And then urine culture and sensitivity. Now, the other additional investigations that D-dimers and PTINR can be done in case the child is actually very, very sick and having a cytokine storm or at risk of thrombosis. Next, please. So in a specific treatment for COVID in newborns. It is newborns, we actually do not have COVID like treatments. We have particular drugs to use in newborns. Hello? Okay, so we don't have particular drugs to be used in newborns, but what we do for these children is to admit. Sorry, again, I'd been muted. So the specific treatment is not there in newborns, and those fancy drugs are not currently being used in newborns. At the moment, we admit these babies and evaluate them to see in case they could be having birth asphyxia, or they are having neonatal sepsis, or they are having meningitis. And in case you find symptoms similar to that, or then the child should be treated for that. For children, for newborns who are not symptomatic, there is no particular treatment that is required, except probably supplementation with vitamin D. Now, for those who are symptomatic, other than treatment with antibiotics in case of sepsis, the others are supportive treatment. So we encourage adequate feeding with breast milk, and this can be done by breastfeeding or by expression of breast milk. And then we need to help these newborns with nasal decongestion, given the fact that they are obligate nasal breathers. If we leave them with congestion, they may actually get serious respiratory problem, and this can be sorted with just normal saline nasal drops and suctioning as required. And then temperature control is basically through exposure of the newborns. We don't often use paracetamol like you would use in older children and adults, or other things, and let the baby cool down. And then oxygen support for those who need oxygen, who are having respiratory distress. And this oxygen support should be advanced gently from simple nasal prongs in case the distress is not allowed to CPAP. Intubation during COVID is really a tricky situation, and really for those who are having severe respiratory symptoms, they are at risk of rehydration, and also for those who are not feeding well. And most importantly is monitoring, because they can change condition anytime. So we encourage the nurses and health workers to monitor these babies who are symptomatic at least every 2 hours and document these findings to see if there is improvement. So with that, if the baby gets better, we look at the discharge and home care. In case the baby was asymptomatic at delivery, as we said, we usually do the COVID test after 48 hours. So after 48 hours, they can be admitted in the hospital for 48 hours. Just for observe 48 hours, the COVID test is taken and the baby can be discharged with the mother and then home. So it's important that phone contacts are taken, because we want them to keep moving. But no need for them to wait for COVID results. And all the IPC we talked about for the mother and isolation within the room continue even when they got home, for at least vaccinated before discharge, and as I've said, a phone with physical visits. So for those who were sick, once the symptoms have resolved, they should be allowed to go home. There is no exact number of days they are recommended to stay in hospital. Once the symptoms have resolved, they should be discharged to go with the mother. So thank you so much for listening.
Yes, thank you,
I will invite Dr. Chiwanuka.
Yeah, Dr. Chiwanuka is going to take us through his slides in the next few minutes. Dr. Shwanuka, you're welcome.
Thank you very much, Dr. Ngonzi. I'll be taking us through anesthesia options for the cesarean section in the patient with SARS-CoV-2 infection. Under the outline, I would like to look at a comment on the national guidelines on perioperative care. I will look at the organization for the surgical operation, then options. Under that, we shall look at the neuraxia and general anesthesia, then a comment on anticoagulation, and how to deal with it, and then pain management for the patient, especially post-operatively. So when you look at the third edition of the national guidelines on management of COVID-19 in Uganda, you have about 1/3 pages dealing with perioperative care. And well, there is no mention of one of the common procedures, which is the cesarean section. Very difficult to apply. So you'll find me relying a lot on what has been done elsewhere and our local experience. Again, when you look at the patients who are high risk for developing severe disease and complications, there is no mention of the pregnant women. I had a look at the team that came up with the guidelines, and unfortunately, I couldn't find even one obstetrician participating in this. So again, probably based on the education they got from the first wave, where we had very, very few cases, they thought they could eliminate them. But with the second wave, we found that there are quite a number of pregnant women who have been affected by COVID-19. So when you are looking at the patients, as a reminder, we've classified them into the mild, moderate, severe, and then the critical. But there is asymptomatic for some of the associations, so we've got to be mindful of that. And this is going to help in addressing some of the issues that you deal with in anesthesia. They say that success really loves preparation, and we've got to be very mindful of what we are dealing with, and organization of the entire service really affects some of the outcomes. How will the patient be transferred to and from the operating room? Minimizing the number of staff in the operating room and in the theater to try and minimize patient to health worker spread. Then locally, practical solution or strategy for donning and doffing PPE. We've got to be mindful that this is a disease that has changed our thinking. Not many theaters in Uganda were constructed with the idea that you could have an airborne disease. So we've got to be thinking about that as we look at the management of this patient. Intraoperative supply of emergency drugs or equipment. Sometimes you're in the operating room, you've donned, you have the patient, but you need something extra. How will you be able to get that? Intraoperative record of care. In Uganda, we are still relying on paper. And so we've got to write, but where does this paper go? Where does the operation record go? Is still a big challenge. And then provision of safe post-operative care that has been addressed. So when you look to the right of your screen, you are going to see that a lot of the equipment there has been covered by polythene, and that is to try and prevent aerosols from the patient going and settling on the machine, which is going to be very difficult to clean afterwards. Trying to prepare and making sure that you have airborne protection becomes key. Ideally, you would want to have a negative pressure operating theater. There are not many in the country that have that. This provides a reminder. It is a checklist that has been developed by Smile Train, Lifebox Foundation, and the World Federation of Societies of Anesthesiologists. And it is supposed to be used in conjunction with the WHO surgical safety checklist. This is to remind us of the critical steps to protect the patient, to protect the health workers, and to make sure that we are doing the right things the right way as we deal with this patient, both intra and postoperatively. So ideally, you would want this to be an elective procedure. Unfortunately, in the country, most of them are done as emergencies. Okay. We've looked at the pathophysiology by the previous speakers of how COVID-19 affects the pregnant women. And so we should be, as anesthesia providers and all the entire care team, look at the patient in their entirety and look at anything that is supposed to affect what the outcome of the patient is going to be. Even when it comes to labor analgesia, you are given options, but let's remember that you would want to come up with a plan as quickly as possible to use neuroaxial anesthesia, that is either spinal or combined spine and epidural, or epidural, that should be placed early, so that as you anticipate anything that happens, then you are going to panic less and hence come up with the best outcomes. The most experienced and knowledgeable anesthesia provider should be doing this, not someone who is going to fail, so that we end up intubating the patient in the process. Oxygen supplementation is discouraged, but you can do that just in case the patient, before delivery, the patient is saturating between 93 and 95%. Only to remember as well that this is a source of aerosolization, which puts the entire team at risk. So if you are to supplement with oxygen, please make sure that the patient is putting on a surgical mask and your nasal prongs are going to be underneath the surgical mask. So just remind you, the patient should be moved to the theater with a surgical mask, not a cloth mask. Challenges of a single shot spine anesthetic. There's going to be worsening anesthesia, worsening hypoxemia, for the reason that the adequate block should be up to the level of T4. And this is definitely going to compromise some of the accessory muscles of respiration that may be in use. Usually, it is going to be much easier to breathe for the patient once the baby is delivered and you've removed the increased intra-abdominal pressure. The other thing that has been recorded, there was a Chinese paper that talked about worsening hypotension, but this has been critiqued. But let's remember that this is a patient, as you progress to this with the severity of illness, they are more likely to need vasopressors. So at some point they may get your patient who is already showing signs of sepsis. And that is definitely going to affect how much you have in terms of hypotension. The other challenge that you have with a single shot spine anesthetic, which is the most commonly used, is a challenging pain management postoperatively. Because if you've used your bupivacaine 3 to 4 hours after your operation, it wears off. And then the patient actually ends up in severe pain. Sometimes, or for one reason or the other, you may find that regional anesthesia is contraindicated, or there is lack of time, like a category 1 cesarean section, or failed regional anesthesia, or a deteriorating COVID-19 patient. So you may have to revert to a general anesthetic, and this becomes a physiologically difficult airway. First of all, the patient is pregnant, so there are changes in the airway that affect the pregnant woman. But on top of that, they are likely to desaturate much, much faster. So you need to prepare for a rapid sequence induction and have as much, or have a qualified assistant to help you. In some hospitals whose protocols I looked at, this intubation happens with the rest of the surgical team outside of the operating room. Because like we shall see later, this is an aerosol generating procedure. If possible, you have a video laryngoscope with you. There are not many in this country. So, but the video laryngoscope helps to increase the distance between the anesthesia provider's face and that of the patient. Apply the same measures and monitors for any other surgical patient. Use a highly efficient hydrophobic filter, and if possible, discard the entire circuit after. I know this may be challenging in terms of supplies in different hospitals. Try to avoid coughing at the time of extubation. Immediate postoperative surveillance in theater. So you do not move this patient to another post-anesthetic care unit, keep them within the theater for recovery, and then move the patient from the operating theater back to the designated area so that you try and avoid contaminating the rest of the theater if you do not have a designated one. So this simply shows a list of, of the procedures that are associated with aerosolization, like nebulization, oxygen administration over 5 liters a minute, bag of mask ventilation, okay, endotracheal intubation. And to note that the risk of exposure is highest for the anesthesia team because they are closest to the patient, but is shared by all the operating room personnel. Postoperatively, it is key that we manage the patient's pain as best as we can. Intrathecal or epidural opioids are very good, but let's be cautious with amounts that are administered because of the delayed hypotension that has been documented. The use of NSAIDs and paracetamol is encouraged, but be mindful of what the organs are functioning like. So the best options may be your regional blocks, something like a transversus abdominal spleen block. This requires that you still have the people who know and can do this safely. Why do we want to manage the pain very, very well? For the simple reason that if the pain is not managed very well, we are not going to be able to have this patient breathing properly. If we are asking them to do deep breathing exercises and they are in pain, then they are going to have abdominal splinting and they're not going to be able to do this very well. The other thing is when you want them to be mobilized, it's going to be more challenging. So let's be mindful, and probably along the same lines, I would encourage that we do more of a phanestomy other than a subumbilical midline incision. A word on thromboprophylaxis. So one of the cornerstones of COVID management with increasing severity is low molecular weight heparin. What you are seeing, that graph is looking at a study of the anti-10A activity versus the time factor. And if you look at the solid line in the 3rd trimester, at 12 hours, the effect in the non-pregnant patient at 12 hours is basically equivalent to the effect in the pregnant patient at 6 hours after administration. So these people are going to be clearing this much, much faster. So someone already alluded to the fact that how to handle and when to give and when not to give low molecular weight heparin. If you just scan that barcode, you are going to find, sorry, the QR code, you are going to get that paper that will be giving you the guidance on when to do the regional anesthetic or the neuraxial anesthetic after what duration of time. And the last thing that I would want to look at is when do you reinstate the low molecular weight heparin after the operation. So you are going to be looking at a period of about, if you are using low molecular weight heparin, depending on the dose, you are going to be looking at waiting for about 12 hours after the operation, and then you reinstate that. If you really think that the risk is too much, then you may have to use an IV unfractionated heparin, which you may have to give just after about 1 hour. So in summary, we need to be looking at, we need to review the patient with the medications that they are taking, because they're going to affect our outcomes and our choice of anesthetic mode. Preferably, let's have them planned as much as possible so that we can organize the systems. Neuroaxial anesthesia is recommended. Theater practices should be aimed to avoid contamination and spread of SARS-CoV-2. And then postoperative pain management and thromboprophylaxis should be looked at in detail. Thank you.
Yeah, thank you very much, Dr. Dr. Joseph. Yeah, we have our colleagues from the ARACOG. They are going to take us through their experience. You're very welcome. Yeah, please go ahead. We also request our participants to hold on. We would want to extend for at least 20-30 minutes, and then the Secretariat will carry it on from there. So you're welcome, Michael.
And I'm Brian as well. I'm Brian McGowan, an obstetrician from Scotland. And just first of all, thank you so much for the invitation. I have been extremely impressed with the high quality of the presentations today, and I think it's been an exceptionally good webinar, and it's a real privilege to join it. So thank you for sharing, and I'm confident we have learned much as well. I think it's useful to explain a little bit about what's happened in the UK, but I've also taken the opportunity, just as you were speaking, oh, I can't move my slides on. Yes, I can. Just to kind of emphasize, these are some thoughts I've had while you've been speaking. The first is that I would agree completely. This is a multi-system disease. It's not an upper respiratory tract infection. It's a multi-system disease. It is, and so many people have emphasized heparin, it's very prothrombotic. And it's difficult sometimes to diagnose because, as the first or second presenter pointed out, the D-dimer is raised in this condition anyway. I was also interested in your, we've also found that the white cell count has been generally low, and if the white cell count is high, we are wondering if something else is going on. We've discussed treatment, and there are lots of different sorts of treatments, but oxygen is absolutely the key, and getting that available and making sure it's available has been fantastic. And I've deliberately put it in 3 times to say oxygen, oxygen, oxygen. This is about getting saturations above 94%. And I think that matters probably more than anything. 2 or 3 minor differences. I noticed there was a comment about using remdesivir. We had been using this and have looked at the literature on it, and think it's probably not particularly useful. So we have decided in the UK to step back from using this. So we've decided not to use it. I noticed there was a comment on using monoclonal antibodies. I think when taken from serum, these probably don't help. There is a new preparation which is still at the research stage, or just completed research, and yet has to gain a license. But I think there will be some monoclonal antibodies coming through in the next few months that might be useful. I know in the chat there's been quite a few comments about, does COVID cause problems to the baby? We've again looked at the literature quite carefully here, and we're very confident that COVID, even in the first trimester, doesn't cause any fetal abnormality. And we've also looked at the same data on whether vaccines are safe, and absolutely. There's a very good series from the US with 120,000 women who've been vaccinated, and there's been no evidence at all from that of any abnormalities for the baby. So we've been very proactive in encouraging vaccination in pregnant mothers, no matter what trimester they come along with. I was interested in your comment in seeing IUGR. We're not seeing that. We did see a slight increase in stillbirth, as Mike will mention when it comes to that point, but we haven't seen much in the way of IUGR afterwards. And we have been scanning people, but it's not been a big issue. I was also very interested in your comments on neonatal COVID. We've virtually never seen this in the entire country. Some babies presenting with problems that we thought might be COVID, in fact, turned out to be other things. So I was very interested in, and thank you for your presentation on that. That was very useful. I think we'll be brief, and I'm conscious that time is against us, so we won't take long on this. I'm just going to say a little bit about how we prepared whenever we were aware that this was happening. And then Mike is going to say a little bit about what actually happened and how we, as a group of obstetricians formally through our college, moved forward with some guidelines and so forth. So moving to the next slide, which is not moving again. I apologize, why is it not moving? Just to say that this is how we've also had two peaks. I think your peaks are rather behind ours. The peaks were roughly in the same size. I note you've had a relatively small peak and you're now in a bigger peak. We had two. The orange ones reflect the numbers of cases, the blue ones the number of tests, and we had more testing available later on. So just talking about this very first part here, whenever we saw this exponential rise, and the big problem with exponential rises is that they tend to rise very exponentially and very frighteningly. And we were concerned that our hospital was going to be, swamped whenever this happened. And I remember very clearly this presentation here, where one of our hospital team came along and said the number of children that number of COVID patients that you're expecting are 3 times bigger than the size of your hospital is. We spent a huge amount of time preparing for this. We looked at the opportunities of getting tents outside the hospital. We looked at people who organized weddings and getting them to bring marquees and build things to get ready. We were expecting a massive wave at the start. And yes, we had a big wave, but thankfully the lockdown was just enough to protect us from that. And much as you guys have done, we went through a lot of exercises, particularly through in theatre and in labour ward, as to how we moved patients, how we changed our masks. If they went from a low risk to high risk situation, did we wear ordinary masks? Did we wear the N95 masks if required? Did we have enough PPE? So we did a lot of work around preparation for this. And the other thing that we did was how, if we're very busy, all of us looking after sick patients when they come into the hospital, how do we look after the rest of pregnant women? So we cut back our antenatal care. We did fewer visits. We did fewer scans. We managed to get hold of some cheap portable blood pressure monitors and gave these to women to take home with them who thought they were going to get preeclampsia, and gave them advice to phone up. We didn't want pregnant women coming along to the hospital if they could avoid it, because they were at risk of catching COVID, or our staff were at the risk of catching COVID. So we tried to do as much by phone or video that we could. We divided our labour ward into 2 halves. We had a COVID half and a non-COVID half, so that when women came in with COVID positive, they were looked after on one side of the ward with staff wearing N95 masks. And we had another side where they just had standard care with ordinary masks, and we found that very helpful. We also divided our staff into teams, because we were concerned that if one group, if someone in a group or a consultant or a registrar or a midwife got COVID themselves, then they were at risk of spreading it to the other team, and that team might have to go off. So we tried to keep our teams separate so that we weren't all having to be at risk of catching COVID at the same time. And our most basic knowledge at the start was that we needed to keep the oxygen high. We were unsure about steroids at the start, but you were quite right. The evidence has come through in that. And I noticed that you were using dexamethasone as a preference, and we do that as well if we're wanting fetal lung maturity, exactly as you did. Our preference, if we have it available, is to use prednisolone if we're not looking for fetal lung maturity, because it crosses the placenta less well. So our eventual situation was, rather than having 3 times of the hospital full of COVID patients in general, it was only about 2/3. So we had about 60% of the hospital was for COVID positive patients, not all maternity. Fortunately, maternity, we never had more than 1 or 2 at a time. And thankfully, most mothers were relatively well with it and had good outcomes. So yes, it was a difficult time. I think it was, and I think it's also worth acknowledging to everyone on this group that that there's an element of fear. There's an element of personal fear. What happens if I catch COVID? What happens if I take COVID home to my wife, to my grandparents? What is the implications of that? So I think we have to acknowledge that there is an element of anxiety and fear, and to support each other through that. UK-wide, there were preparations where we built much bigger hospitals. We took a big warehouse or a big building and converted it into a specific COVID hospital, but thankfully we didn't get to the point of using that. No one had actually worked out who was going to staff it, which is a small detail, but we did get to the point of having to do these, and thankfully didn't need them. So those are really our preparations UK-wide, and I'm keen to then hand over to Mike, who can then tell us where we kind of went from there. Mike, over to you.
Thank you very much. And I'll just echo Brian in thanking you for inviting us today. So we had a first peak, as Brian said, with a lot of uncertainty, learning a lot of new protocols. Next slide, please. I'll just talk a little bit about the overall numbers in the UK. So the UK obstetric surveillance system keeps track of all pregnant women who were admitted to hospital with COVID-19, so with a positive test. And over the first year of the pandemic, so from March 2020, there were about 5,500 pregnant women admitted with confirmed COVID-19. And in an average year, there are about 700,000 births in the UK. And the risk factors in the UK were having a minority ethnicity background, a raised BMI, comorbidities such as hypertension or diabetes, older maternal age, and economic deprivation. Next slide, please. So most of the women who were diagnosed with a positive test in pregnancy were asymptomatic. And this is principally because routine screening on hospital admission and in labor was brought in. However, nearly half the women did have some symptoms, and while these were usually mild, cough, fever, fatigue, nearly 20% of the symptomatic women required oxygen treatment, and 1 in 10 symptomatic women was admitted to an intensive care unit. Now, the threshold for admission to ICU was quite low, and most pregnant women who went to ICU spent only a day there, and most were not intubated. But nonetheless, about 1 in 200 symptomatic pregnant women died from COVID-19. Next slide, please. And as has been mentioned in the excellent talk so far, we've seen fetal effects as well. So in the UK, for symptomatic women with COVID-19, the preterm birth rate was 2 to 3 times above the background rate. And this was quite a marked effect for symptomatic women, but not seen strongly for asymptomatic women who just had a positive test on routine screening. There was also an increase in the stillbirth rate, and this is newer data. Next slide, please. Which showed that women who tested positive for COVID-19 when they came into hospital were more than twice as likely to have a stillbirth. And it's not entirely clear what the causal pathway there is, but there are a number of studies from the UK and elsewhere showing placental abnormalities in women with COVID-19. And this is the most likely cause for this. Next slide, please. So the Royal College of Obstetricians and Gynecologists first role was to try to provide clinical guidance for doctors working in the field. And early March, a guidance cell was convened, and a few days later put out the first version of our COVID and pregnancy guidance. And there have been multiple spin-off forms of guidance, some to do specifically with the management of COVID and some to do with changes to our services. For example, how do you provide an early pregnancy scanning service when you're trying to keep women out of the hospital? And after multiple iterations, the latest version of the COVID-19 pregnancy guidance was published in February, and we're expecting another version in August of this year. Next slide, please. So the initial advice from the vaccine regulator in the UK was that pregnant women should not be given a COVID vaccine. However, that advice was changed quite rapidly. And on the 30th of December, the Joint Committee for Vaccination and Immunization in the UK recommended that pregnant women could have a COVID vaccine. And so the RCOG then became involved in vaccine education and advocacy. And we've been putting together things like a vaccine information sheet and decision aid, which are really aimed at convincing, well, informing pregnant women on the vaccine safety. We've had webinars and also advocating to the National Immunization Committee to try to ensure that pregnant women really are eligible for vaccination and that they're not being turned away from vaccination centers. And finally, there's been a data collection push. Some of it to try to get firm numbers for safety reasons, but also looking at vaccine hesitancy. So while the vast majority of adults in the UK are willing to have a COVID vaccine, about 2/3 of pregnant women in the UK have declined vaccination. Next slide, please. And finally, about a week ago, we released our COVID-19 vaccination and pregnancy guidance, which I've uploaded into the chat bar for this webinar. So looking back over the past year, we had the first peak with a great deal of uncertainty, a very steep learning curve, and then quite a hard lockdown. And after the success of the lockdown, the cases were low through the summer and things seemed okay. Next slide, please. And then we hit our large second peak. In here, we were much more confident in how to manage COVID-19 clinically in pregnancy. But as the cases rose and rose, it was the sheer burden of disease that threatened to swamp the system. And that prompted a second hard lockdown in the UK and cases came down. Next slide, please. And this is where we are now. So cases until a few weeks ago were low in the UK. But with the advent of the Delta variant, we're now entering a third peak. We have good vaccination coverage in the general population, but still relatively poor vaccine coverage in the pregnant population. And we also have a year of backlog of gynecological surgery and other routine care, which needs to be caught up with. So we started with uncertainty and we're back to uncertainty again. How do we restore normal services? How do we promote vaccination for pregnant women? And we still don't know what effect the Delta variant will have as it spreads further and further through the population. Next slide, please. So thank you again for inviting us and thank you for your attention. And I'll just make a little plug for the RCOG COVID guidance and vaccine information on our website, which you may find useful. Thank you.
And thank you very much for that, Mike. And just to back that up once again, the situation we're at the minute is trying to reassure people about the vaccine situation. And having looked at the literature and as I said to you, there's a very large number of cases now where women have been vaccinated and gone on to deliver afterwards. It seems to be extremely safe, and our big work now is how do we get that message across, because I'm very reassured by it. I know my colleagues are and our midwives are, but it's how we start getting that message across to people that vaccination is safe. And I know some vaccines are now becoming available in Uganda, and you may find yourself, even the number of questions that I saw appearing in the chat there suggested you're also having the same issue, is people quite very rightly wanting to protect their baby. But if we know there's an increased chance of stillbirth, if we know there's risk factors that affect mothers, and we know that the vaccines are safe, then I think we really need to advocate very, very strongly for vaccination and pregnancy. And that's a big situation of where we are now. So I suppose that's my number one key message to you as the vaccines come in through, that we need as clinicians to confidently advocate in favor of vaccines for pregnant women. Thank you very much.
Thank you, Brian and Michael. yeah, plus your great team from the Royal College. Yeah, we just want to thank everyone before we hand over to the Secretariat to resolve this webinar. We noticed that many questions were coming through the chat, and answers were being exchanged in the chat window. I would have loved to have many more questions or comments at this point, but because our time is fast spent, we want to extend our gratitude to everyone who participated, from the hosting team to the Secretariat, which will finally be able to give the closing remarks. People who joined in from different parts of the country and the East African region and the UK. This is a topic that has generated very excellent participation. We hit a cap and many more people were sending us messages saying they're in the waiting room. We hope that in the very near future, we'll have another aspect to this. I'm not trying to be selfish as an obstetrician, but another topic around COVID in pregnancy wouldn't be a bad deal. Take-home message is the vaccination, and we need to advocate for that so that our precious mothers, are safe. So thank you, the Secretariat. Over to you, Dr. Kajimu, from the hosting team. Thank you again. And we hope that our paths will cross in the not far future from now. Dr. Kajimu and the team at the Secretariat, please, over to you.
Thank you very much. Handling the IT issues, but we have been privileged to at least shed some light on the so many uncertainties that health workers have faced in dealing with COVID-19 in pregnancy. We agree that this is just the first of the series, like we've stated in the comments. We're going to have maybe a few more series on COVID-19 in pregnancy and how we can go ahead with managing them. And I think what we can promise is that let us be on the lookout. We'll share the links as soon as the team has sat down and identified the need. We also acknowledge the fact that so many questions have not been answered that have been asked. So we'll compile them, and maybe in one of the sessions that we'll have, we'll maybe have a feedback on some of the questions that have been raised. And we just want to remind again that NASMEC was ready to ensure that health workers are able to learn as much as possible from different colleagues and from different partners. We are very privileged and we look forward to working with most of you in the near future. We want to recognize all the great lecturers from the different institutions, from Makerere, from Bara, from Bositema, from Guru, and the different implementing partners, not forgetting our Ministry of Health, which provided all the necessary support for this webinar. I want to hand over to Richard or Grace if they have one or two things to comment before we can officially close this session. Grace, Richard, any other comments?
Thank you very much, Dr. Eladu. Can you be able to get me?
Loud and clear.
Okay, perfect. I would like to thank the teams for attending today. We are so glad, and we apologize for any inconveniences caused about the limits of participants, but we are definitely working on this. And with this being an overview, we are looking forward to having particular topics of COVID-19 and pregnancy. So all your views have been captured, and we're going to still share a link of this presentation on the YouTube link that has been shared on our channel of the NASMEC. Thank you very much. Over to Dr. Kajimu.
No comments from me. We can close the meeting.
Goodbye, everyone, and see you soon.